Hello and welcome to HIMSS '09, the IHE exhibit integrating the healthcare enterprise. We have with me today John Donnelly, president of Interpro Solutions, who is also the co-chair of the Patient Care Coordination domain. We also have Tone and Jason from Greenway Medical Technologies, and we'll be speaking today about the IHE. John, may I ask you about this amazing exhibit? We have almost 60 different companies and entities here actually accomplishing what we've been discussing for years, which is having various disparate entities transmit health information from one to another. And you know more about this than most, maybe more than anybody. Can you explain that to us?
Thank you very much, Dr. Fishman. The showcase that we're speaking of here is the product of many months of work. Actually began last summer, where the vendors here, who are typically competitors in the industry, come together to solve interoperability problems. And we present problems to them that are real-world problems, such as maternal health or emergency referrals or things like this. And they then step up to put into their systems code that lets them exchange in a standards way. So they can write one interchange for participation with many partners. And they come together to test this out before we get to the showcase. So we take these 60 organizations, and actually at the what we call a connectathon, it's actually probably 85 or 90 organizations. They bring their systems, we hook them up, and they test out what's going on. So if you could imagine 350 software engineers all acting as comrades in arms to achieve interoperability, it's an amazing event. And today is the culmination of that work. We bring them here. We let the attendees of the HIMSS exhibit come by and see actual use cases be demonstrated with information, clinical information, privacy, security, access controls, information exchange between physician offices and public health agencies. It's just a tremendous breadth of coverage of the healthcare information technology arena.
And John, as I understand, this has been work that's been addressed for many, many years, and many physicians are of the opinion that this is something coming tomorrow or coming next year. As I understand it, people can go through this exhibit and actually, with respect to their own healthcare information, go from one booth, enter some information, go to another booth. It will be retrieved in a different company's systems, and it's actually, here it is April 2009, and it is working now.
That's 100% correct. The real strength of what we're doing here, not only at the demo, but it's also to indicate that these are different systems and we're working with standards interchange and standard information interchange. And so what you see, and you come in and you actually register yourself as what we're calling the HIMSS patient. And you register yourself and you will see your record moving with your medical summary and with information that gets added as you go from step to step. So it's not smoke and mirrors, it's not something going on behind the curtain, but it is actually things which people have in their products, and that's a very important thing. I just want to mention one thing, because they don't get a lot of notoriety here, is that behind the scenes there is one group of systems, and that's what we call infrastructure. And if you could imagine a health information exchange, a community of systems, of hospitals that want to exchange data. To make this work, they need to get together and build some basic components of infrastructure, a registry, some repositories, a gateway that lets them talk to other registries, a way to cross-reference patient identifications. These are things that are kind of prerequisites to any one doctor system exchanging data with any one hospital system. And that we also have here, and they are really the underpinning of what you see.
Thank you. I have one last question. I've spoken with some participants, some exhibitors, as well as some of the visitors. They say that it's working essentially flawlessly here. I understand that there are some pilot projects in the country, and just your estimation as to when this will be a common event in the United States, that I, as a Florida resident, could fly to California and have my information at essentially any outpatient facility or hospital available. How many years do you expect that to take?
Well, I'm always the eternal optimist. At least I've been told that. I have seen tremendous growth over the last couple of years, and I'll be honest with you, as much as I don't like to say money talks, but we now have some money that we actually can put behind this, which will get us over that initial hurdle. And that's is planned to actually be worked into the process within this year, with monies then being available through the process through 2010. And so I'm thinking pretty short time that we would have this pretty widely spread, and some are further along than others. So there are definitely communities that we will see that this year, that there will be some interchange based around the standards that we're seeing here.
We're now speaking with Tone and Jason, participants in the IHE. You're both from Greenway, but in addition, you're both tightly integrated, if you will, into the IHE. Can you tell us from your perspective how this is functioning? And I'm going to ask for a little bit of an emphasis. There's quite a number of acronyms in this industry, and if you could explain to the viewers some of those acronyms and why they're important to them.
Mm-hmm. Sure, absolutely. So we're involved with a lot of the XDS scenarios, so I'll just jump right into the acronyms. So XDS is Cross Enterprise Document Exchange, and what that means is we can have a document in our ambulatory EMR system, and we can submit that to the registry and repository that John was speaking of earlier. Another EMR ambulatory system can then retrieve it from that repository, so we have interoperability. So XDS is one that we're using there. Some of the ones that are paired up with XDS include ATNA. ATNA stands for Audit Trail and Node Authentication. And so the idea behind that is, as we send documents around to these HIEs, we need to have a trail of what's happening with them.
And the HIE is?
The Health Information Exchange.
Yes.
So, or RIO, as it was formerly known as. So we want to know who sent it, what time did they send it, did it get there, did it fail out, so we can track back and see where your information is. The other side of the node authentication piece of that acronym is for the security between the ambulatory system and the registry and repository. Another piece of the puzzle is consistent time. And consistent time just ensures that when you're exchanging documents between disparate systems, they have the same timestamp. As you know, if we're in different time zones or clocks are off, and it's very important with discrete clinical data to have those times aligned.
Some of the acronyms within the quality perspective is what we term RFD, Retrieve Form for Data Capture. So what that is used is for, particularly within the exhibit, is showing biosurveillance. So we, as an ambulatory system, can present a form on a trigger. So if a diagnosis is seen within our application, we can trigger a form and pre-fill that form with data and then submit that back to agencies such as the CDC. Other uses of RFD are in clinical research. So another phase of the QRPH work group, and presenting a case report form for clinical trials into an ambulatory system and pre-filling that with data. All of this is using standards-based and follows the building blocks that we're building upon here within the different domains. So Patient Care Coordination Committee, which Tone is co-chair of, is another building block which Quality Research and Public Health help build on.
I see dozens of acronyms around the room here, NIST, CAQH. Can you just tell me briefly about some of them? We're all familiar with CCHIT, and I believe there is a likely relationship with NIST as far as what entity is creating the standards that these interoperable systems will be working on.
So how it works is IHE profiles existing standards to solve interoperability problems. HITSP lines up with IHE, so HITSP creates constructs, and then CCHIT uses HITSP for their certification pieces. So that's kind of how it all ties together, and that's why we're on board. I mean, it's important to follow CCHIT certification, and CCHIT certification points to IHE ultimately. So,
anything else that either of you would like to address to the audience?
Yeah, I think so. One thing that's really important to see is a lot of what we see around here is document exchange.
Yes.
So you see somebody submitting a document, they're retrieving a document, they're viewing it. You see that what you don't see is the discrete data behind the scene. There's a lot of systems that are still working on that. So that's very much an end goal. But these documents we're exchanging, they're structured such that you will be able to import and export discrete data into and out of your system.
And so if there's a narrative portion, such as the history, where somebody fell or what restaurant they had an injury at, is that narrative, which is not, in my opinion, data, transmitted from one system to another? Is that
yes? And so how we define it? So Jason mentioned PCC, which is a Patient Care Coordination Committee, which I co-chair. So we define these content profiles, which deal with the narrative sections and the discrete data sections. So when I say discrete data, so you can have discrete data for anything. So you have a medication. For that medication, it's also going to have a narrative text, a section in the narrative text that it points to. So all these documents are human readable. You're going to get the narrative text, whether it's just a note about what happened, a progress note, or whether it's a medication that was recorded.
Again, I'll point to the different scenarios that are here and the different workflows. So you have the biosurveillance as well as the document exchange site-to-site transmission. So I think that's very important. All the different uses and the building blocks that we have here and the usability that's there, as well as the discrete data and the standards we're using. And you'll see the interweaving that all these scenarios are playing and the building blocks that we are using across the board.
As a potential patient in the future, I thank both of you for doing this wonderful work, and I think it will absolutely help the quality of care going forward. So thank you, gentlemen.
Thank you.